Thank you so much. I'm almost sure that nobody knows where Slovenia is because it's such a small country. But perhaps for the rest of you, the President Trump's wife is from Slovenia, so at least he should know where this country is. Again, it's a pleasure talking to this event, and I'm going to jump to my slides. And before I go there, I have to disclose I'm a consultant for Livanova at the present moment. Otherwise, I don't have anything to disclose.
That doesn't look good.
I will talk about suture-less valves, and
do we have this slide?
Addressed this as an excellent option.
Dr. Gersak, I'm sorry, 1 second. David, we need the slide that says that this presentation is... It's there?
It's right there at the bottom.
Okay, I'm so sorry. Okay, Dr. Gersak, thank you. Well, it's so far away, I can't read it. I thought it had to be a whole slide. Okay, never mind. Moving on, Dr. Gersak, please.
So I will talk about sutureless valves, and at the present moment there is only one valve available on the market, which is called Perceval. And why I said this is an excellent option for the surgical aortic valve replacement, because this is not a competition to TAVR, but maybe it is a competition to other surgical valves. So obviously the name of the valve is Perceval, and it doesn't come from the mythology. But it comes, or let's say from the history, but it comes from the abbreviation.
Uh-oh. Hello? Somebody want to let them know we have a problem?
Yes.
Sure. You want me to talk?
Team.
Okay. Here, Dr. Gersak, we've lost your voice. So I don't know if you can hear me or the studio audience, but we are obviously having apparently an NBC Democrat debate technical glitch, and we're working on it. So, okay, are you back?
Yes, I hear you. Do you hear me?
Yes, we hear you now. So we've missed everything you've said up to the point of your first slide.
Okay, so I'll go back. Obviously, I will talk about sutureless valves. And I said this is an actual option for the surgical aortic valve replacement. The Perceval name comes from percutaneous valve. And at the beginning, this valve was supposed to be a TAVR valve. And this percutaneous valve somehow transferred into the surgical valve. And I'm saying the Perceval is the surgical TAVR in a way. The first in-man study was done in 2007 in Europe. And very soon in 2011, the valve received CE mark for patients over 75 years of age. And just 1 year later, for the patients over 65 years. In 2014, there was a CE mark for adult age, and very luckily in 2016, there was an FDA approval for the use in the United States. If you want to compare this valve and anything in the surgical world which is new, we have to address and compare this with the gold standard. And what is gold standard? Gold standard is the sternotomy, of course, sometimes minimal invasive surgery, and of course stented valves, biological valves. If you want to compare new technologies, and especially Perceval, we have to say that we should have excellent short-term results. This means low mortality, of course, no strokes. We should not have any paravalvular leaks, which are a little bit problematic in the TAVR world. And of course, we should have the proven durability of the implanted valves. And I will address this, each of them. And I will put a little attention to the perfusion as well. Not too much, but just to remind the perfusionist that sutureless valves can help in making the patients to have better outcome. So if we are introducing new technologies, we should always aim that our CPB time and cross-clamp time should be, of course, shorter. we should have really good myocardial protection, and because minimally invasive surgery is getting more and more attention, we should have smaller incisions, but not to make our results worse, but to make our results better, not even equal. What we can say about aortic valve surgery is that incidence is growing, and that we have higher incidence of comorbidities and higher risk profiles, so that the patients are more and more difficult to operate. And I'm sure that every surgeon in the United States and everywhere in the world where the TAVR is introduced is facing these issues, more and more complex patients and more difficult patients. So this is the slide which is demonstrating the cumulative count a number of aortic valve procedures over the last 10 years. It's a little bit old slide, but still it reflects the reality that aortic valve replacement is getting more and more attention, and of course all other combinations as well. Everybody knows that no one wants to have a longer cross-clamp time and longer CPB time. So what does it mean? If we have a cross-clamp time which is about 60 to 90 minutes, and we compare this with the cross-clamp time, which is more than 90 minutes, we can see that in hospital mortality, hospital length of stay, ICU stay, blood transfusion, ventilation time, and of course, very important, renal complications are much worse if our cross-clamp time is more than 90 minutes. So it's important to reduce the cross-clamp time and CPB time as much as possible. But the surgeons are saying, is it important to reduce the cross-clamp time by 10 minutes? Of course not. But if you look at this slide, you can see that the older the patients are, the more important it is to reduce the CPB time and cross-clamp time. If you have a cross-clamp time 1 hour and the patient is 40 years old, you can have about 3 to 4% morbidity risk after the surgery. But if you are 80 years old, this goes to almost 13%. We are facing the patients who are 80, 85 years old, and if you look at the cross-clamp time will be 90 minutes, you can see that you can have almost 20% risk of cardiovascular morbidity after cardiac surgery just by itself. So if we compare the Perceval, which is a sutureless valve, and I will tell you what this valve is, how does it look like a little bit later, but if you look from the operative times in comparative studies using the Perceval and other valves, especially Intuitive, which is an Edwards valve, we can see that individual cross-clamp time can be reduced up to 50%, maybe 30%, which is not the case in the other valves at the present moment. So individual cross-clamp time can be reduced up to 50% just by using the sutureless valve technology. Well, I mentioned about gold standard. Gold standard, of course, are stented valves, and we can see that if you compare the stented valves and the Perceval, that postoperative gradients are much lower in the sutureless group. Also, what we can say that those mean gradients remain significantly lower and actually are going down in time, which is not the case for the conventional stented valves. If we compare the mortality using conventional and sutureless valve, everything goes into the direction of sutureless valve. So much less mortality, better hemodynamic results on the long run. So Perceval and the sutureless valves. This is a study which was published in Annals of Thoracic Surgery in 2014 showing the operations in right anterior thoracotomy using Perceval versus conventional AVR. And you can see that from the time of follow-up, everything goes into the direction of sutureless valves. So conventional valves somehow didn't work so good as the Perceval in right anterior thoracotomy, which is, of course, probably the most difficult approach in the aortic valve surgery. So what is the Perceval valve? The company says, and it's very interesting to repeat this, it's a game changer in surgical tissue valve replacement, and is designed for any patients that requires surgical AVR. This is important, surgical. This is not a competition with TAVR. It's a surgical AVR, including complex cases. So if you mount a pericardial tissue on a stent, which is a nitinol stent, you can get this Perceval. And as you see, there is this nitinol stent looks like a spring. So it's reducing the stress on the leaflets, as I'm going to show you later on. So if you mount this valve, which is called Solo-Smart valve of the bovine pericardium, on the stent, you can get Perceval valve. So let me show you what is this, the Perceval. This is an animation, of course, and I hope you see this. This part here of the valve sits on the annulus. This part down sits below the annulus, and we have the struts here, and obviously we have the valve which is mounted on this stent. What is important to see is that the part of the valve you see here, it's always open when it's implanted before removal of the cross clamp time. Sometimes the surgeons are concerned that there will be a central leak, but it's not, because the pressure is closing this gap, and actually this is a very good representation how the valve looks like. You can see that you have certain relationship between the annulus, which is somewhere here, and the ST junction, which is here. And those struts here are going into the sinuses. They are in the shape of the sinuses. And this part here, which is straight, this is the commissures. And these parts are actually not touching the aortic valve wall at all. So these parts are touching the aortic wall, and this part is not. And as you see, this strut is designed as a spring, which also helps to minimize the risk of coronary occlusion. So even if the stent goes inside the coronary artery, let's say left main, it acts like a stent. But this is really actually very rare. Let me go back to my presentation. Just a second. So I mentioned there's a part of the valve which is below the annulus. So obviously the paravalvular leaks are the problem. And when we compared the ratio of the paravalvular leaks comparing conventional valves a couple of years ago, we saw that the paravalvular leaks are almost the same. But remember, this was a few years ago, 2015, 2014, maybe 2016. Now in 2019, with the proper implantation of the valve and with the proper steps, we can say that the number or the percentage of the paravalvular leaks can be equal to 0. So nothing is 0 in life, or just, let's say 100 and 0, just life and death, but everything is in between. So we can say that it should be 0.001 or something like this. So probably we will not face the paravalvular leaks at all. And this is showed by this slide. This is a meta-analysis of the cases done in the study period from 2007-2013. The number of paravalvular leaks with the knowledge how to implant the valve went drastically down, almost up to 0%. So what did we learn? We learned that the valve should sit with the collar on the annulus, that we should decalcify annulus really thoroughly, and that the part of the valve which is below the annulus should not be blocked by any calcium which is below the annulus. So as you see, the design of the valve is really the same as the TAVR valves. It's a stent and the pericardium. So the only difference is, of course, besides cross-clamp time and CPB, that we are excising the valve and we are implanting the biggest possible valve into the annulus, which gives us the perfect option that maybe later on, because the valve is so huge, if there is a need, we can also do a valve-in-valve procedure. Some surgeons actually use this valve-in-valve procedure, and you can implant even the smaller size very, very big TAVR valves. I'm not saying that this should be done regularly because the valve is really excellent in durability, but there may be cases where this would be needed, maybe because of some other problems, or maybe because of the structure of valve deterioration after many years. So because the valve is unique and you will see it's collapsible, we can ask ourselves, can this valve, the sutureless valve technology, actually facilitates the minimal invasive surgery approach or penetration in the markets around the world? And the answer is yes. So if you see that just by introducing Perceval on the market, especially in Europe, the percentage of minimal invasive approaches for the surgical AVR went from almost, let's say, 5% up to 80%, in some centers even to 100%. One of the benefits of the Perceval is its collapsibility of the valve. So when you use this valve in minimal invasive surgery, you can actually see everything what you as a surgeon need to see. So this size is M size, and the outer diameter where the stent is 18 millimeters, which is really small, and the valve is 23 when it's fully expanded. So you can see really good. And point is made. This valve is collapsible. It's not crimped, and you will see this. What does it mean? So this is a small short video showing how this valve is implanted in right anterior thoracotomy. And this is 50% speed because I wanted you to see really what's actually going on, because the valve deployment is so fast that if you miss it, you can do it in a couple of seconds and you don't see this. You have to do arthrotomy a little bit higher than usually, and it has to be transverse. You have to do a complete decalcification. This is extremely important, that the calcium will not interfere with the stent. Sizing is crucial, and it's very important that you size the valve with two different sizers. One is transparent and one is white. It goes beyond this presentation how to do this, but then the guiding sutures are introduced and the valve is positioned, put into the parachuted down. Then the inflow tract is exposed, is deployed, and then the outflow tract as well. And at the end, you have to balloon the valve. This balloon will not prevent any paravalvular leaks. It will just make the valve totally round, because, you know, the annulus is never totally round. It's oval. This valve is geometrical, it's circle. So it's in a way making both of them fit tightly together. You have to inspect the valve, and you have to remove the guiding sutures. So this can be done really in a couple of seconds, and the surgeons who are using it regularly, they can have a cross-clamp time less than 20 minutes, even in minimal invasive cardiac surgery. There's a big difference between Intuity and Perceval. Intuity is a little bit bulky valve. I used also Intuity, so I can talk from experience. This valve is not collapsible. It's not really not really very good, in my opinion, for minimal invasive cardiac surgery. And there are many differences, which are, of course, that you have a nitinol, a stainless steel alloy for the Intuity valve. And this part is pushing below the annulus, and no wonder why the Intuity has a little bit bigger percentage of AV blocks compared with the sutureless valves, Perceval. But it's also important to understand where the valve is exercising the stress. The Perceval has the stress distributed around the sinuses, and of course also below the annulus, but the Intuity also below the annulus. And because of the Perceval, about this unique shape, it's very important to understand that we have to obey a certain relationship between the annulus and the sinotubular junction. If the sinotubular junction is more than 30% wider than annulus, this is not the proper valve to be implanted. So it has to be up to 30% and not more. Normally, the STJ is about 10% wider than annulus. The valve is collapsible and it's really pliable, flexible. This is a video showing how the valve really moves during the cardiac cycle. It's actually is resembling the movements of the annulus, of the aortic wall, of the ascending aorta. So if you implant a valve which is too big, you will have this situation. You will have the of course, oversizing, and this oversizing, you see, it's really severe. You will have a paravalvular leak where this big hole between the annulus and the cage is. Of course, you don't want to do this. With this valve, it's very easy to oversize. So we pay a special attention that when the surgeon is sizing, we have appropriate valve implanted. This video shows a relationship in the triple valve, and this is mitral valve replacement, tricuspid valve repair, and the Perceval inside. You can see that you can use this valve in really difficult and complex cases, and this is a CT scan after such a procedure. This is another video showing the relationship between the mechanical mitral valve in this case and the Perceval. I mentioned oversizing, and these are two excellent videos showing you what is happening if you do one size up and two sizes up. One size up, you see you have a ring close, you have like a curved leaflets, and this movements of the leaflets, which is not really very good. It's fluttering and so on. So the effective orifice area is really bad. If you do the two sizes up, it's even worse. You see much lesser effective orifice area, much more curves on the leaflets when they are together. So not a really very good picture. So this is how the valve should look like at the end of the implantation. You see a perfect straight triangular shape, 120 degrees, and when the valve is opening, you can see that really a very good effective orifice area, almost the whole part of the valve is exposed. Durability issues are very important. So if you are crimping this part, this valve, which is a TAVR valve, into this small balloon expandable stent, you will get a certain damage to the pericardium. On the upper left corner, you have a normal pericardium with a non-crimped valve. On the upper right and lower left, you see the pericardium after the crimped valve. So this is not the case with the Perceval. I mentioned this is the collapsible valve, and if you collapse the valve, you see that when the valve is collapsed, just the stent is affected. The leaflets are not affected at all. And if you see what is going on, if the valve is collapsed almost by 3 hours, you can see that there is practically no damage to the pericardium. And we can maybe say that the valve will be more durable than the TAVR, but this is just a theoretical consideration. I mentioned to you that you have to compare with the gold standard, and the gold standard still in the surgical world are stented valves. So let us look what is happening. This is a high frames per second video recording, 3,000 frames per second, showing mosaic valve and what is going on with this valve when the valve is closing. Please pay attention on the commissural part. And now I'll repeat this again for you to see this. So look what is going on with the commissures. So practically there's nothing going on with the commissures. And what we have here is the magna. And again, pay attention to the commissures. You will see that the commissures are moving a little bit. I will do it again. Are moving a little bit toward the inner side of the valve. So this way they are reducing the stress in this part. If you look at the Perceval, you will see that those movements are much more positively aggressive, of course. And also pay attention on the stent. You will see that the stent is also working as a spring. So it's moving. So we can say that the stress on this valve, on the commissures and all around, is probably much less, like in the car suspension with air suspension or whatever. But of course, we have to obey and respect in this valve anatomical considerations, so that the STJ will not be more than 30% wider than annulars. And there are certain contraindications which are getting less and less important, because now the people and the companies are just asking for another approvals. With the surgical experience around the world, this is changing rapidly, and there aren't many contraindications. Oh, by the way, one of the contraindications, which is really absolute, is the sensitivity to nitinol, because the stent is from the nitinol. So going from a low complex operation, which is full sternotomy, through mini sternotomy to right anterior thoracotomy, we are facing higher CPB time, higher cross clamp time, and higher learning curve. But with the Perceval, with the sutureless valve, we can reduce the cross clamp time, we can reduce the CPB time to a certain event. And a little bit about the perfusion. So what I've seen normally, the minimal invasive surgery is done through the femoral perfusion. Just rarely the surgeons are using direct aortic cannulation. They're using femoral aortic cannulation. And in this case, we are facing the higher arterial line pressures. This will perfusionists will well known. So, and risk of the dissection or whatever. And these are actually my cases, hundreds of cases which we did, actually for the mitral valve surgery, not for the aortic with the femoral aortic cannulation, but it's the same if you do it with the aortic valve. And also, because of this, you can see that the perfusion on a body surface area during minimal invasive cardiac surgery is a little bit smaller, lesser than if you do the normal cardiac surgery through the direct cannulation and direct approach. And I borrowed this slide from a Denver GDP meeting in 2018, which perfusion is probably very well known, goal-directed perfusion, that the advocate perfusion is yet an art rather than an exact science. And I would like to encourage every surgeon, every anesthesiologist and every perfusionist to look deeply into this goal-directed perfusion, because even if we are reducing the cross-clamp time, reducing the CPB time, we should pay attention also to other things which are going to improve our patient's outcome, and especially the acute renal kidney injury. And this is one of my last slides. It's a right anterior thoracotomy video showing a percutaneous femoral vein cannulation to reduce the damage to the atrium, let's say, to the right atrium, obviously. This is the guide wire going through the femoral vein into the superior vena cava, which is verified by transesophageal echo. Then we use this cannula, of course, to take the venous drainage. This is incision for drainage afterwards, which is below the xiphoid. This is a surgical view. This is a second intercostal space, really small incision. It's about you see the size of the finger, of the length, and opening in the second intercostal space. There is no rib cutting, no rib removal, just a little bit of exposure with the retractor. And you can do this just with the really small valve, with the collapsible valve. You can actually not put the big valves inside. And even if this is a small incision, you can see everything. Because of this unique valve. This is the aorta, a little bit left on the left side of the sternum. Pericardium is opened and pulled towards the right side of the patient to pull everything towards the surgeon. Then the cannulation for the aorta will be done directly almost in the arch, just below the innominate artery. And as I mentioned before, the venous cannulation will be done percutaneously through the femoral vein. This is a purse string just below the innominate artery. which will be used for the aortic cannulation. Dilatation of the skin, and using various dilators, of course, because the cannula is 23 and 25 French, goes into the superior vena cava. As you see here, the holes are going in the SVC, then there is nothing in the right atrium, and there is 25 French going into the IVC. This cannula can be used also for the mitral valve, for the tricuspid valve, not just for the aortic. You see this is in the SVC and IVC. Aortic cannulation with the direct incision into the place below the innominate artery. Then, of course, cross clamp will come. And then cardioplegia. A cardioplegia line directly where the incision will be. And this is actually very good for the minimal invasive surgery because the orthotomy is a little bit higher. It's getting much more surgeons friendly. Cardioplegia, transverse orthotomy and sizing, which is crucial. Of course, the vent is inside, making surgical field bloodless. It's very important to see what you are doing. And as you will see, even despite the incision is small, you can really see everything. Now the Perceval goes down. It's already on the annulus, and then a very short deployment, visualization. The valve should be perfectly round. There should not be any annulus below. And the de-airing is sometimes very problematic in the minimal invasive surgery. This is what I use, and some surgeons around the world are using it as well. So it's a direct CO2 into the ventricle through the right superior pulmonary vein. There's a small hole which is letting the CO2 out. This de-airing is really a couple of minutes, and then removal of the cross clamp. Of course, the pacemaker wire is implanted before this removal. The heart starts to beat, and a really simple removal of the percutaneous femoral vein. Just a small stitch, obviously not too deep, no compression, nothing. The patient can walk the next day. And remember, there is no damage to the right atrium. There's nothing, and this in a way is helping a little bit, of course. To prevent the post-operative atrial fibrillation, and we use in all the patients. We use this catheter to reduce the postoperative pain. So at the end of my presentation, I would like to say that the very famous man in the history said, "The knowledge of what is today does not open the door directly to what should be." So probably, of course, after 10 years, 15 years. Then we will have new technologies, and we don't know what we don't know. But at the present moment, we are lucky to have this technology available. And it's also very difficult to predict the future. This is a famous RAND corporation which predicted how the home computer will look like, I think, in 2004. So this is really totally inappropriate prediction. So it's very difficult to predict what will happen 10 years, 15 years from now on. But we can say at the present moment, we can say that with the use of sutureless technologies, we have the patients who can benefit from this technology. These are the patients who are sensitive to cross-clamp time. These are the patients who are in the need of faster recovery. And these are the patients who have technically challenging procedures, or they are at risk of patients' prosthesis mismatch, redo, small annuli, calcified roots, old patients, obese patients, and so on. So there are many, many patients who can benefit from this. And this is my last slide. I think we should use every technology in the proper way. So not every patient is suitable for every technology, and not every technology should be used in every patient. So we should use them Like this old gentleman said many years ago, that the medicines are nothing in themselves if not properly used, but the very hands of the gods if employed with the reason and prudence. Thank you so much for letting me talk about the sutureless valve on this meeting, and I'll be more than happy to answer all of your questions. Thank you so much.
Very good. Very good. So Dr. Gersak, in deference to time, your time, would you prefer for me to give my presentation on standby for TAVRs and then have the discussion? Could you bring Dr. Gersak up?
Yes, of course. Yes.
Or would you prefer for just to respect your time, because I'm not sure what you're doing? Would you like to go ahead and answer questions now, and that way you could be done? Which would you prefer?
I would prefer whatever suits you, or maybe what suits our audience, which are listening and looking at this presentation the best. So it's up to you to decide.
Okay, well then we're going to ask your questions now, because your talk is far more interesting than mine. I have a whole host of questions. Anyone on our panel, and then I also got some questions from the audience. So,
I would like to know, what is the average cost difference of the Perceval valve compared to what we're using normally, and compare that also to a TAVR valve?
Thank you. This is a very good question, because everybody in the world is very concerned about the cost issues. So what we can say is that this valve is much cheaper than the TAVR valve. I would say really much cheaper. It depends on the geographies. Let's say in Europe, it's about 3 times cheaper than TAVR. I'm not so sure about US, but for sure it's cheaper. I know, maybe 2 times. It is a little bit more expensive than the classical valves, obviously, classical standard valves, but not so much. And it depends also on geography. Let's say in Europe, I would say it's around 5,000 to 6,000 euro. Here in US, probably the same in the terms of dollars. Somewhere else in the world, where the people have to pay for themselves, it's about $10,000. And can you imagine that the people believe, and the surgeons who are recommending this valve for the patient, and the patient has to pay for this valve for this amount of money. So the surgeon really has to believe in this valve. So, but if you, the cost of the valve is of course important. But if you compare the overall cost for the patient's treatment, you can see that if you use this valve, sutureless and rapid deployment this valve as well, that you can reduce the total cost, because the ICU stay is much less. There is much less transfusion. There is much faster recovery. And in Europe, they did studies a couple of years ago, compare the classical valves and the sutureless valves, and the cost difference was about 3,000 euro going into the benefit for the sutureless valves. So I think for the society by itself, if you compare the TAVR and the sutureless valves are much less demanding in costs. But I'm not saying that everyone should use the sutureless valves. You know, the TAVR is an excellent option, but you have to balance. So if the patients are suitable for the surgical AVR, there's nothing wrong doing surgery.
Mm-hmm.
Right.
Very good. Tammy, Ro, any questions?
No,
I actually have a question about your cardioplegia administration.
I was going to ask that.
Could you tell me a little bit about, do you use standard cardioplegia? Are you using Del Nido? How much are you dosing? I know you're probably very fast with your cross clamp, so you're probably only having to give an initial dose, but I'd like to hear a little bit about that.
It's an important question, because we have so many different cardioplegias, so many different techniques. So I will answer the question in 2 ways. So how actually I do, and many surgeons around the world are doing the full sternotomy or mini sternotomy, where you can access all parts of the heart With this, I mean you can use the retrograde cardioplegia. If you do the right anterior thoracotomy, doing the retrograde cardioplegia directly through the direct cannulation is not really reproducible unless you use the percutaneous transjugular catheter. Going back to your question, I use personally a cold blood cardioplegia, St. Thomas 4-to-1. In right anterior thoracotomy, 1.2 to 2 liters. It depends on a patient. And this cardioplegia will last about 45 minutes. If there is a problem, we can always give the direct ostium cardioplegia, but with the right anterior thoracotomy, there may be a problem because if you don't see the right coronary artery, you may have a problem. At the beginning, the surgeons are using, when they go to minimal invasive cardiac surgery, using more or less a very effective, long-lasting cardioplegia, and they are using also custodiol. But when you are getting faster and faster, the custodiol is not really very good because you have to wait that the effect will wear off and so on. So I would recommend at the beginning, of course, when you go from major incisions to minor incisions, you go from, of course, very effective long-lasting cardioplegia, and then you gradually go to the normal one, let's say, maybe blood or... I never used Del Nido because Del Nido was basically used for the children, and it's also very long-lasting. If you are really fast, then you almost have to wait for half an hour that the heart will really start to be declining in the proper way.
Okay, thank you.
Very good. Well, you brought up something that's very near and dear to our hearts, and that is on your mitrals. Since you do a lot of minimally invasive cases, and you just mentioned that on your mitrals, how do you give your cardioplegia? You clamp and give your. I'm assuming you use like that articulating clamp that goes in. Have you ever tried, or have you ever considered not cross clamping the aorta on your mitrals at all? I know Dr. Petrasic did the fibrillatory arrest, but giving the patient a very large dose of systemic potassium to go into diastolic arrest and then do the mitral replacement or repair, and then using CVVH or continuous hemofiltration to remove the potassium, and that way you wouldn't have to touch the aorta at all or have any ischemic time at all. Have you tried it, or would you consider it?
This is a very complex question, and of course, I tried many things in my life during surgeries, and this is not as strange to me that you give a high dose of potassium and the heart is really arrested, but you have to cool the patient down, and maybe up to 29 or 28 degrees, maybe even lower. Sometimes you use this technology or this technique if the cross clamp time was not really applicable because of various reasons. What I frequently use, especially in the past, it was so-called aortic and mitral valve surgery on the beating heart. I started to do the so-called mitral valve surgery on the beating heart maybe in the year 2000, maybe even before. And the heart was really beating, so it was contracting, it was not fibrillating. It was done with the continuous retrograde coronary sinus perfusion with oxygenated warm blood. So direct cannulation through the sinus, coronary sinus with the purse string, the flow of the really warm blood going through the sinus, of course, monitoring the pressure and so on. And the heart was really beating. Was very good to evaluate the quality of the mitral valve repair after this. But of course the cross clamp was there. The aorta was clamped because to prevent the air going inside the brain or whatever.
Sure.
And we used this also for the aortic valve surgery. Actually, one of our colleagues he did a PhD thesis comparing this beating aortic valve surgery with the normal cardioplegic aortic valve surgery. And what we found out is that if you do your surgery on the beating heart, in the time frame of about 45 minutes, this surgery will be much more effective than if you lose the cardioplegia. Because when you remove the cross clamp, of course with the air, the heart, you remove the cross clamp, the heart starts to beat, and immediately, because it was just working all the time without any pressure load. And what we found out in almost all our patients, we have to put vasodilators because the pressure went really, really high up. Mm-hmm. So it was totally opposite. So the pressure was high, not low. And we said, now, because if it's complex surgery, the cardioplegia is good and so on, there's not so much difference. But if you have a really bad ventricle with a bad ejection fraction, then I would recommend you use aortic or mitral valve or both on the beating heart. Yes.
That's interesting.
How much more difficult was that for you to perform the operation on the beating heart?
If you talk about aortic valve by itself, it was not much more difficult. The point is because the blood is flowing through the retrograde and it's coming back from the coronaries, mm-hmm. and it goes down to the ventricle. Mm-hmm. So as soon as the ventricle, which is beating, has a load, it starts to eject. So it's crucial that you have a very good vent inside the left ventricle. So it has to be empty, and it's not so much difficult. But what is the benefit? And it's really very beneficial to see how the annulus is behaving during this beating heart aortic valve surgery. You can be surprised how really tight and how strong the annulus is. So this is how you can learn, I would say, the proper sizing, what is really happening when the heart is beating. About the mitral valve on the beating heart is a little bit more difficult, because the heart is full, not inside the ventricle, but the muscles are full. You know, it's not like a sac. It's full of blood because the blood is flowing through the coronaries. So you need a special technique. You have to cut a little bit more of the normal. I use the transeptal approach, but then you really have to cut also a little bit into the left atrium as well, so above the roof, to make the valve exposure a little bit better.
Thank you.
Very good. I think a question on all of our minds, you know, in light of the recent data that was presented by Dr. Reardon, his group at Houston Methodist Hospital here at Texas Medical Center, on the outcomes in the low-risk TAVR trial or case study that they did, where with the core valve, it was equal to SAVR, and with the SAPIEN, the outcomes were actually better than for surgical AVR. So that's kind of I'm predicating my question on that recent data that was presented by that group. Histologically, and you alluded to it in your presentation, there are significant changes that happen to the valve tissue, the pericardium, that they crimp versus the folding or the collapsing with the Perceval sutureless valve technology. How is that translating, and what is the data on short and midterm early graft or early and midterm graft failure or valve failure? In other words, where is TAVR going to go versus SAVR with this newer technology, based, especially when you talk about the low-risk patients, in terms of taking over that part of the available cases? Where do you think that's going to go?
So obviously, the TAVR is an excellent option. And if you ask anybody in the world what you would like to have, a surgical cut or percutaneous valve replacement, everybody who is reasonable would say, of course, I would like to have something which is less invasive, which is less painful, and so on and so on. But you have to have also two considerations. What is the cost of this? So if this is really, really very expensive, then if the society cannot really really support all this, like millions of patients or 100,000 of patients, this is one thing. And the other thing is, what will be the durability, of course. So if you are very young and you can, of course, withstand a little bit of pain, maybe the surgical option will be better for you because you don't know what will happen in 10, 15 years because of durability issues and so on. If you have to pay for something, it's also different. So, but being in US, which is, of course, similar to Europe and to the northern or western hemisphere, durability is very important. But at the end of the day, there will always be a surgical patient, always. There can be maybe double valve, triple valves, coronaries, maybe some complex cases. So what we are saying, if we think reasonably, like being a patient, not just a surgeon, we can look what we'll do for ourselves. So if there will be a surgical valve, indication for the surgical valve replacement, I would say the sutureless valves is probably the best option at the present moment. If I will have the indication for TAVR, why not? Because it's easier, it's faster, it's much less painful, and so on and so on. But going back to durability and about crimping and then collapsing and so on, if you compare the stented valves, the sutureless valves, and the TAVR valves. So look at about the stented valves. So this is undamaged pericardium. It's perfectly intact. But then you have a stress which is on the commissures. The second is sutureless valve. You have, of course, collapsible valve, probably non-damaged pericardium, and less stress reduction. Well, more stress reduction, I'm sorry. And then you have the TAVR, which is really crimped valve, so damaged pericardium. I don't know, because I don't have the videos, how the valve is behaving on the commissures. So we can, at least I can say that low-risk patients, we will see what will happen in the future. If I will be low risk, seriously, I would say maybe surgical option will be best for me because of the durability and because of all the known problems, all known pitfalls or whatever. And it's also very important how you present to the patient. So if you say, let's say, if I'm a surgeon and I'm telling you as a patient, what would you like to have? I will cut you open from here to here. I will put you in CPB machine. Your heart will stop. Your blood will flow around outside your body. This is one option. The other option is TAVR. You will go home tomorrow. So everybody will say, I would like to go back home tomorrow. But if you say the surgical valve has proven durability, there is no paravalvular leaks, would you consider this option? So this is more non-biased compared to the TAVR. So you have to say to the patient the facts about both technologies, and then the patient, of course, with your help should decide. You should not force one which you believe. I think that the patient should choose, knowing all the benefits and all the negative, positive effects of both technologies.
Mm-hmm. I think that's very well put. Very, very well put. Do we have any further questions for Dr. Gersak?
I have just one last technical question. If you were talking about doing the retrograde cross-clamp beating heart, if you do the the right anterior thoracotomy approach, do you have the room to put in a retrograde?
It's a very good question. Thank you so much. I forgot to mention this.
Okay.
This technique, doing this on the beating heart with the right anterior thoracotomy is probably not a good idea.
Right. Yeah. Okay, that's what I was
the retrograding.
If you have a very small incision, but if you want to have incision like this is not minimal invasive surgery anymore. Yeah. So I'm saying don't force this technique into the right anterior thoracotomy. This is more or less for full sternotomy and mini sternotomy. Right anterior, I don't think it's a good idea.
Thank you. Thank you for clarifying.
Thank you.
Okay, very good. Well, I would say, Dr. Gersak, thank you so much. We appreciate your time and your presentation. And it was very informative, very helpful. And all I can say is thank you.
Thank you.
Thank you.
Thank you.
Thank you so much for allowing me to present this. Obviously, I strongly believe in this technology. If I would not believe, I would not present. Hopefully, we will meet again in the next future. Who knows?
Well, we hope so. And since you're spending a lot of time in Europe, we would certainly welcome some of your colleagues, some of your perfusion colleagues, or other surgeons who may also want to present. You probably didn't see my opening remarks, but we do have, I think, a very good platform here. And if you know some folks that may have an interest, or you have continued interest in wanting to lecture with us, please reach out to us and let us know. I think you know how to get a hold of me, and we'd love to hear from you or any of your colleagues in Europe, and maybe we can do some collaborative work together, which I think would be fantastic.
Thank you so much. I have to admit, I have to tell you, I was and I'm impressed with the level of knowledge of perfusionists here in US. I'm impressed. And with all these groups who are making a continuous effort to make the patients better, and also looking into the other options like goal-directed perfusion and so on and so on, I think there is a lot of room, not just here in US, but all over the world, how to, just with the perfusion, how to make the patient outcomes better. And I'm always saying there are three pillars in the cardiac surgery. One is, of course, surgeon, which has to operate. The second one is anesthesiologist. But the third one, very, very important, and even more than very important, is the perfusionist, especially for the minimal invasive cardiac surgery. You can have an excellent anesthesia, you can have an excellent surgeon, but if the perfusion is not good, you can forget it. So perfusion is really important.
Well, thank you, sir. We appreciate that recognition very much. That was very kind of you. And we'll just look forward to hearing from you again someday soon. And I hope that we all have a chance to meet you soon, too.
Thank you so much.
Thank you. Good day.
Thank you.